All right, welcome back. This is our fourth and final video in the first month of the new clinician development program. This one is entitled Do Not Miss Conditions. You can think of it as kind of a review of systems and some things that will or likely ultimately diagnosed by a physician, but their signs and symptoms and presentations can often show up in front of you as a physical therapist, as a clinician in your clinic, and we need to be aware of them. Some of these conditions include DVT, pulmonary embolism, femoral head and neck fractures, and then the others there are kind of more neurologic in nature, cauda equina and cervical myelopathy, circulatory issues, cardiovascular issues, and then some psychosocial kind of pieces to end the lecture. So if we put them into categories, a lot of them will be sign and symptom based versus diagnosis specific. There wouldn't be too much overlap of signs and symptoms, and therefore we would use clustering to kind of help us versus a condition that we might see, such as diabetes or high blood pressure. There would be some overlap of some signs, some symptoms, and that really it would be the recognition of the condition, and the physician would then make the diagnosis. So if we take our first step into some of these things that will show up, particularly in our postoperative patients, we'll see DVT as an incidence of roughly 70 per 100,000 in the general population. But as you know, as PTs, we're going to be seeing postoperative folks, and so they're not the general population. They're a specific population postoperatively, and so we see a increase in the lower extremity DVT. I don't have a particular percentage, but we see a fair amount more than I would say 67 out of 100,000. And then as far as the moving on to kind of a little bit more significant pulmonary embolus, you will see a certain percentage of those move into that category. And unfortunately, some of those folks actually do succumb to the pulmonary embolus. There were certainly a lot less of them recognized and found prior to kind of the Wells criteria clinical prediction rule being developed in the late 1990s. With some additional kind of studies, and now there are more than 14 different articles if you look back over the recent literature. So DVT is one that we will take a look at. Essentially DVT, we're looking at the venous structure in the leg. The superficial femoral popliteal and the posterior tibial vein are the more common areas that you'll see them, with the superficial femoral being roughly 70 to 80% of the DVTs. It is interesting that most of them there, whenever our main kind of clinical symptom is tenderness in the calf. And so if we look at literature, you can see an interesting article in the early 2000s. There was a national study of physical therapists where they gave 6 different case studies and asked them to categorize them as low, moderate, or high probability. And unfortunately, almost 1,500 PTs, several of or large categories of this did not even recognize the high likelihood. And so it was a opportunity for us as a profession to kind of step back and look, are we really starting to kind of be more aware of these things? And I think over the last 15 to 20 years, the awareness has certainly increased in our postoperative kind of clientele. We tend to take calf tenderness, increases in swelling, redness, pain much more seriously now. So what are we looking for if we're suspecting a DVT? You can kind of use the QR code there to download Wells criteria handout that I've put together, as well as just kind of reviewing the slide and some of the symptoms here. We'll see that typically in the patient history, you'll have some type of immobilization or surgery or just a sedentary lifestyle. Not uncommon to see folks with a little bit of high blood pressure, a little bit overweight, take an airplane flight, maybe 3 or 4 hours in duration, and develop a DVT because of just being still for that long. So somebody gets off the plane, says, "Oh, my calf is really tender, must just be a cramp," and before long they're starting to notice that it's swollen and red. That's definitely a sign that you want to get kind of looked at. So you'll move into the second kind of piece here where you'll see the signs. You'll see definitely swelling of the entire lower extremity, redness, tenderness, and the collateral vein fullness, where you see those veins quite full. Very similarly, if you were to give blood or go to the lab and have them take blood, they use a tourniquet around your upper arm so that they can get the brachial and the cubital vein to really kind of be more prominent because they become full, because they can't move any fluid, any blood back to the heart at this point, so they become full. And then alternatively, if we're thinking, okay, what else could this be? We're really looking for some other explanation for the signs and symptoms. Have they been walking with what we might term as a touchdown weight bearing gait or a toe touch weight bearing that would make the calf work more than it typically would, and therefore that calf muscle is sore because of that? Do we have an alternative explanation that would give us a reason that this person would be that sore? So we're clustering, we're using the symptoms, we're using the signs, all as a way to kind of start to think about, all right, what else could this be? And so that we then have this Wells criteria and a way to interpret a lot of these signs and symptoms that we're seeing, and then we score it. And so we would take all of these pieces here and kind of look through them, and then they each come with a score of either 1 or 2 as an alternative. So if you're seeing a score of 0 or less, they're low risk. 1 to 2 is moderate, requiring a D-dimer test or imaging, typically an ultrasound, and a score of 3 or more indicates a high risk, necessitating an immediate ultrasound scan. This is with the person that you would send on down to the emergency room or the local ultrasound screening place that day. So I need you to get this taken care of. So going through each one of these, you can kind of take a moment and look at them. You can stop the video if you wanted to, and kind of you'll see the score out next to it. The one thing that I'll say about this alternative diagnosis, at least as likely as a DVT, that would be where, is there another explanation? Are they walking differently? Have they done something differently? Did somebody hit them in the calf with a bat? You know, what is it that explains this alternative diagnosis rather than a DVT? Right. So they've got something else that explains it. You would take 2 points off, and then you would score that. All right. So looking at the progression of the DVT to a pulmonary embolus gives us now a Wells pulmonary embolus signs and symptoms. Some of the things that we may see as signs would be difficulty breathing. They would have kind of chest pain. They may even have a cough. This one right here is one that I've experienced several times where they have a rapid change in their personality. They become apprehensive. They become anxious. They may even have fever to go along with a cough. This one right here where they have kind of this, they're coughing up blood, that's definitely a red flag. That's not normal. We would obviously send them to the emergency room for those things. So the change in person, the change in their breathing pattern or pain with breathing, a cough, rapid onset of fever and so forth, just becoming more anxious. They definitely need to be screened by a physician, likely in the emergency room. Again, here's kind of just a table view of that criteria that you can kind of refer back to. So our next kind of don't miss would be femoral head and neck fractures. You see some kind of just general stats there, the second most common pathology in the general population. The reason that we're talking about it as a don't miss is because it has such a high mortality rate within 12 months of onset, up to 30%. Or said differently, 1 in 3 people will succumb to a femoral head or neck fracture. Mortality rates are unusually high, typically because they're in the hospital. They may develop a nosocomial infection, or they may have other comorbidities that become more pronounced because of the immobility that they go through after the neck fracture, femoral neck fracture. All right, so just some kind of risk factors here on this slide. Osteoporosis is certainly one. The insufficiency fractures, typically seen in kind of the thinner elderly females, 60, 70-year-olds, most common, whereas we get more fatigue fractures in the athletic young female type of athlete, gymnast. Also in the military, you'll see some femoral neck fractures whenever people start running long distances and they haven't been used to those things. Also end up with pubic ramus fractures and so forth, stress reactions and so on. But again, the most common is the osteoporotic insufficiency or fall causing a fracture. So we end up with pain. That seems to be an obvious complaint. We fall, we have immediate pain at the hip, groin, buttock, greater trochanter. You can also have some thigh and knee complaints as well. That anterior thigh kind of running down toward the knee can be confused with lumbar radicular type symptoms. The key component here is the mechanism. I had a fall. I now have pain that's aggravated with weight bearing and then relieved with rest or non-weight bearing. Whereas we have a mechanism that has no known injury, you might have a fatigue fracture. You may have a stress reaction. And so in a lot of cases, plain films is our method of kind of finding these, and you'll have sometimes a delay in diagnosis up to a couple of weeks because people are just not able to get somebody to listen sufficiently so that they would then send them for the needed imaging to kind of find the problem. Okay, we've starting to look a little bit more at a couple special tests and how to really pick up on patella pubic percussion and the fulcrum test as a way to discover kind of femoral fractures and or femoral neck fractures. And essentially they use the resonance that's created when you tap on a solid structure as opposed to if something is hollow. So if you've ever tapped on your wall at the house, you can kind of move along the wall as you continue to tap. And when you come to a place where there is a structural 2x4 in the way, it'll sound different. And so you'll see some people on these home shows where they'll tap, 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 and all of a sudden it'll sound different. And they go, there's a stud there. Or similarly, if you were to tap on a table and then a box. They sound different. And so you can use tapping at the patella and use the patella to kind of bounce it off of the intertrochlear groove at the knee, and then with a stethoscope, listen to the sound as it translates up the femur to the stethoscope, and then ultimately to your ear, you're listening to the sound that it creates. So it's called the pubic patellar percussion. And then there is also another test that's called the fulcrum test, where you can imagine if you have a stress reaction in the femoral neck, that putting your arm under the leg and creating a fulcrum where you press with the other hand in a downward direction. You're trying to then almost like a seesaw with the femur, trying to lift the patient up in the air. It creates a lot of bending stress within the femur. And if there's a stress reaction or a fracture, this would certainly be something that would be painful for the patient. And not to mention that walking or some other weight-bearing activity could also be something they would be complaining about. All right, moving on to some of the neurologic things that we may see, cauda equina syndrome, as well as cervical myelopathy. The cauda equina being something that is associated more with degenerative disc disease, where you see folks that have degenerative discs, or they have a lumbar discectomy, they could potentially develop cauda equina syndrome, where they have kind of the disc itself compromise the space where the nerves are descending, and in particular, you would have things that would show up from a symptom and a complaint standpoint, things like sensory changes, motor changes over multiple levels. You might have bowel or urinary incontinence, and then saddle anesthesia along with sexual dysfunction. The two things that you might see clinically, these would be more kind of symptom complaints. However, these down here would be the more clinical signs that you would see: an ataxic or a wide-based gait pattern, balance disorders, or even just outright falls. And then the legs becoming heavy and weak. You would hear complaints of, I can't control my legs, my feet don't want to work very well, or you're just outright falling for no apparent reason. That is when you start to kind of really go back and start to see or listen to certain complaints regarding the nervous system. And then you start to ask some of these other questions regarding incontinence and or sensory changes. Okay, the saddle anesthesia really becomes one that is kind of a hallmark of this particular problem. And so that can be one of those questions that you can reference with something as simple as wiping. Do you feel the paper on your skin as you wipe? That would be a way to kind of get to this question. All right, looking at cervical myelopathy as one that is, I won't say it's frequent, but it's certainly there from a possibility standpoint with anybody that has balance, gait changes, and or problems with controlling their hands bilaterally, or they notice, or you notice that the thenar eminence of the hand is showing atrophy. So almost visually, you can kind of tell, hey, this person may have something going on with their neck because the hand piece of their thenar eminence is wasting away. Now, it is certainly one of those things that is a little bit of a challenge diagnostically because it is almost something where you may have some of these signs and symptoms. There's a wide variety of presentations, and they're almost always non-traumatic. And so you end up with a difficulty from a diagnostic standpoint unless somebody is quite used to seeing it at first glance. You typically will see this in your 50, 60-year-olds. There's a presentation that is similar to cauda equina, but you typically have bilateral complaints. There's not a whole lot of pain with these folks, but they definitely have the dexterity, handwriting changes. They have trouble with dressing themselves, buttoning their clothes, gait, balance. High index of suspicion is certainly warranted whenever you start seeing somebody with these kinds of complaints. Cervical myelopathy and or stenosis occurs or can occur from any real direction to the spinal column itself. In the cervical spine, know that we have the column and then the associated nerve roots, as opposed to in the lumbar spine. When you're talking cauda equina, it's obviously just the descending lumbar nerve roots. And so here we could have symptoms show up in any number of regions. It could be bilateral hands, could be bilateral feet, legs, could be both. I've had patients in the past that end up having balance and gait issues that undergo both lumbar and cervical laminotomies and fusions because they've had such bad stenosis in both regions. All right, moving away from the cervical into kind of more of systems, review of systems. We'll have a couple of cardiovascular things to talk about. AAA or abdominal aortic aneurysm would be our first. The biggest thing here are kind of some of the symptoms that a patient may come in with. Low back pain, mid-thoracic, or even interscapular pain, described a little bit differently than your typical musculoskeletal pain. They will describe it as kind of a knife-like or tearing sensation, and it is severe and excruciating as it progresses. Some of the signs or some of the things that we would do from an evaluation standpoint, examination standpoint, might be that they would have a pulsatile abdominal mass where you would be able to see the pulse through the abdominal contents. And there may be kind of some mid-abdominal or left kind of flank low back pain that is unchanged with active screening of those joints, low back and hips specifically. Some of the risk factors that can kind of help you understand are listed here. Smoking and congenital heart conditions where they've had a valve replaced are some of the primary ones. Some of the more uncommon or rarer ones would be folks with EDS or Marfan's. And then kind of you'll see some of the folks where they're doing high intensity exercise. They may perform a Valsalva, and that would produce enough of an internal pressure or raise in actual blood pressure to cause a aneurysm in the aorta. Certainly we think about this sometimes when somebody gets mad when they're holding their breath and they bear down and their veins pop out of their head. You're like, stop doing that. You're gonna give yourself an aneurysm. It's the same thought process with the abdominal aorta. Somebody that may have smoked in the past, had some anterior spinal surgery. Anterior spinal surgery meaning they went through the abdomen to get there. There's just a risk of trauma to the aorta and possibly the renal arteries, and so we're kind of keeping track of past medical history for them. And then now we move into the actual heart attack presentations for both male and female as our other cardiovascular event here. Male signs and symptoms, I think we're all relatively familiar with kind of the left arm, left chest, neck, upper back as the symptoms, with it being kind of a crushing pain. We have some perspiration as well as nausea, vomiting, and so on. The things that show up beforehand, kind of these prodromic signs and symptoms, is that they're very tired, sometimes in the days or week before, and they notice that they have chest pain with just normal activities such as walking or just climbing a set of stairs at home. And then once they actually progress from the heart attack to actual cardiac arrest, they're unresponsive and they have all of the kind of cardinal signs, no breathing, no response, and so forth, of the cardiac arrest. As opposed to the female presentation, it's not the classical pattern that the male produces, more of a central back, central sternal discomfort, pain, sometimes even up into the jaw a little bit. And they most notice it as kind of an indigestion, heartburn type of complaint, possibly with a little bit more anxiousness and shortness of breath, as opposed to the classical arm, hand, chest pain. Now, they will sometimes also complain of kind of achy, heavy upper extremities and feel like sometimes it is improved with antacids. Tough to determine if that's kind of a placebo effect or what's happening there. They do respond to nitro or rest if they have those pills, then they're likely a little bit more aware of the symptoms as well. So again, just noticing that the female heart attack does not follow the classic kind of male presentation, and that you may have folks complaining more about shortness of breath along with indigestion, or I woke up with shortness of breath. I'm anxious because of my shortness of breath. Those kinds of things can certainly be signs that somebody is potentially having a mild, albeit could be significant event if left untreated. And so differential for what we're discussing here, kind of with the myocardial infarction pieces versus MSK, you can kind of read through this. The big one here is kind of the duration, and that it is not relieved or it does not reproduce with kind of active range of motion of the trunk or arm, neck, as opposed to here it is unchanged with range of motion versus musculoskeletal. We could change it with the assessment of those joint regions. So here are our last two depressive disorders and suicidal tendencies. We cover these because psychosocially in therapy, we do see people that become depressed because of their inability to participate, or become suicidal because they've had some type of injury layered with a little bit of depression, layered with that isolation from their typical activities, and those things kind of all combine to cause some of these disorders that we will see. Just a few statistics for you there on the side here. We're going to keep moving with risk factors. Current or prior history of depression, you will see nearly 50% of those folks will relapse. And so one of the things in the history, if depression is marked and you're starting to notice that they've had a significant event, they've lost a family member, and they've got some of these other comorbidities, that there is certainly a higher risk factor, and we'd want to be aware of that. The biggest thing that we can do is a two-question depression screen, with the first question being here shown on the slide: over the last 2 weeks, have you felt depressed or hopeless? Second question being, are you able to do things that you enjoy? Now, obviously, with a lot of musculoskeletal injuries, the answer to this one's going to be no. So if we have a single yes, are you able to do things that you enjoy or that give you pleasure? And the answer is no. Then we would kind of go to the second one. Over the past 2 weeks, have you felt down, depressed, or hopeless? And we get a single yes out of those. The specificity sensitivity is kind of listed here for us. With this kind of first question, this is a little bit of an obvious question. So we have to kind of take all that into context with what we're actually seeing the patient for. Biggest thing that we'll see here is that delayed onset or not asking these questions will decrease the potential for this person to receive or have any treatment for depression should it be present. And then, of course, suicide risk can be one of those things that's difficult to talk about for folks, but it is a leading cause, third leading cause of injury to self and or success with attempts in this younger population, 15 to 24. Some of the things just to kind of general know about it, risk factors. Males have the better completion rate, whereas females have a greater attempt rate. You typically see that it is a white male carrying through to completion. Their social status has taken some kind of a significant change. They have, at least in their past or recent medical history, almost 50% of these people have seen a physician for some of these complaints in the past. They may be unemployed or have a family history of suicide or friend groups where this has been the outcome. And so there will be some statements that you may hear. I can't take this anymore. They're not going to do this. They're not going to get away with this anymore. And some of those things can be just simply the patients being mad at their situation. But we also need to then kind of pay attention and look at the other pieces in their history as well as their social situation and asking questions in the depressive kind of 2-question category, but then also here, I can't take this anymore sounds pretty significant to me. What do you mean by that? Do you feel like you have a plan to hurt yourself, or do you have the ability to hurt yourself? If they're saying, I can't take this anymore, they're not going to do this anymore to me. Those are some questions that logically follow a declarative statement like that. And if you are asking those, you're likely to hear an answer that would surprise you when they answer, yes, I've thought about it. At that point, this person needs to be referred not only to their general physician, but also to psychiatrist, so that they can kind of be brought in on the situation. Some additional things that may pop into their history are listed here with weight change, fatigues, feeling of worthlessness or guilt about something. Sometimes survivor guilt is pretty significant when a spouse or significant other passes. And then you'll see some of these other pieces here that could be some additional manifestations. So overall, this is the conclusion of our video series, and the 4 videos here are part of the new clinician development program. Again, if you have thoughts, questions, or concerns, we can always kind of get together through email, and or you can kind of speak with your local mentor who you'll be introduced to or should have already been at least given contact information for, so that you guys can continue the mentoring process. Always here to help, and enjoy having you on board. So again, congratulations, and we'll see you in the future. Thank you. Bye-bye.